Welcome to the Tarrant County Medical Minute podcast.
Well, hello, everybody. My name is Brian Swift, and welcome to the Tarrant County Medical Minute. I am the CEO of the Tarrant County Medical Society, and I'm happy to be joined by Dr. Jeff Jarvis, who is the MedStar CMO, but soon to be the Fort Worth EMS entity, for lack of a better word.
The EMS system formerly known as MedStar.
There we go.
Exactly.
Better way to say it.
Yeah.
Well, welcome. You've been involved here at the Medical Society. We have known each other now for a number of years. There's a lot that I want to talk about as it relates to emergency medicine. But why don't you tell us a little bit about how'd you get to Fort Worth and how did you get into this business of emergency medicine?
You bet. Well, Brian, thank you for having me. You've been a great friend to me. TCMS has been wonderfully supportive of me and EMS and pre-hospital medical care here. So I really appreciate the friendship, the partnership, and I appreciate the invitation to come and talk. So like you said, my name is Jeff Jarvis. I'm an emergency physician and an EMS physician, dual boarded, and I'm also still a paramedic. I started my career 1 or 2 years ago as a high school student, and I got involved with the fire department, and that led me to EMS. I became a paramedic and worked as a paramedic for 10, 11 years, including teaching and being a state bureaucrat, and realized that what I really wanted to do was be an EMS medical director, and I actually looked up the requirements. It said be a physician. I'm like, it's just 7 years. So I went back to school and went to medical school in Galveston and did my residency in Temple, and that's the same place I was teaching paramedics. I've continued to be an emergency physician, but really my primary specialty is EMS. I'm an EMS physician and EMS medical director. My first role as a full-time medical director was for Williamson County EMS. That's just north of Austin. And then about 2.5, 3 years ago, I had the opportunity to take over for Dr. Vithlani here in Fort Worth. So I came up to Cowtown.
Yeah, and he's out in California.
We
still miss him. He keeps in touch.
He is a great guy. He is living the California lifestyle.
He is, he is. So tell me about, we have a lot of students that participate in the podcast, and a lot of them are unsure, right, as first-year, second-year medical students.
Absolutely.
If you were to advise one of them about going into emergency medicine, what's the lifestyle like?
You bet. Well, that's always a challenge. So the classic answer for a medical student is EM is a lifestyle specialty. This is great. You're on duty until you're not, and then you go home and you live your life. The truth is there are no lifestyle specialties in medicine. When you become a physician, it is a commitment that most of your life is going to be dedicated to your patients.
Right.
Really the specialty, and I'm not saying that there aren't other specialties that spend more time in the hospital. That's clearly not the case. But I think we have to decide we're going to be physicians before we're going to be our specialty physicians. So I'm biased. I think emergency medicine's a wonderful specialty. I love seeing a wide variety of patients, and I love having to build a rapport with patients and their family members at what is often the worst part of their life, and I have about 30 seconds to do it.
Right.
I think it's a skill set that I have. I enjoy that. It's rewarding for me.
Right. So for those out there in the public, because I've never had to dial 911.
Right.
But if I did dial
Thankfully.
911, thankfully, as a member of the public, what kind of happens? What is the process, right? Most people, 911, and then the police show
cavalry
up.
shows up.
Right, the cavalry. Yeah. How does that work on your end?
You bet. So when you dial 911, a little bit of nerdery, your phone is almost certainly not a landline anymore. You're on a cell phone, and the actual cell towers triangulate your location, and then they identify something called a PSAP, a primary or public service answering point. And that is where that call is going to route to. It'll route to that location, and then someone will answer the phone. It's typically law enforcement. And what they will say is, police, fire, EMS, what's your emergency? and then they'll route the call to someone who specializes in law enforcement call taking, medical call taking, fire call taking. Now, sometimes it's the same person, but sometimes you have multiple specialties. We're large enough here in Tarrant County, in Fort Worth, that you get your own specialist. If this is a police emergency, obviously they don't involve fire or EMS, and law enforcement handles it. If it is a medical emergency, then in Fort Worth and in most large municipal areas, we go through a medical process of triage. So there are scripted questions. It's called emergency medical dispatch. We use a system called medical priority dispatch, and it is designed to identify the acuity of your call, of your need, and the best resources. So if we say that you are having an acute medical emergency, time is critical here.
Right.
We're going to send the nearest EMS resource, and we're going to send the nearest first responder resource. In this case, we'll send one of our partners in Fort Worth. Obviously, it's Fort Worth Fire Department,
Right.
And they will respond. So that's the reason if you're having chest pain, if you're having a stroke, you're going to end up not just with an ambulance, but with a fire truck.
Right.
Now, you may end up you probably wouldn't call if you were in cardiac arrest, but if there's a cardiac arrest, you will likely get law enforcement. They can absolutely do CPR. You will end up with not one, but two fire trucks, because we're bringing, the more resources you have on the scene of a cardiac arrest, the better outcomes are. So you'll see two fire trucks, you'll see an ambulance, and an EMS supervisor. Again, the more trained resources you have on the scene, the better the outcome. So you're going to see an awful lot of people.
Right.
Hopefully parking is not a premium when you call.
Exactly. So we have worked, and when I say we, the medical society and some of our great physicians who work every day in the hospitals, these are the people that are running the emergency departments.
Yeah.
And we've worked here over the past couple of years in this changeover that has happened.
Yeah.
And I think a lot of people think about, well, here at the Medical Society, we obviously do a lot of advocacy. So we do it on the federal level when we're talking about issues like Medicare and Medicaid or payment issues. We are right now in the middle of a legislative session.
Always fun in Texas.
Right. So we've been in Austin for the past 4 months doing a bunch of things.
Yeah.
But it was really, I thought, just very unique and a great opportunity for the physician community, particularly our emergency physicians, to come together and work locally with our elected officials, with the mayor, Maddie Parker, who's awesome
she's great.
with us. And why don't you talk a little bit about, why did we? What is the transition that is really going to be taking place? And it's going to be taking place, I think, the switchover, even though you've been working behind the scenes. Yeah, right.
In a matter of minutes. Right.
Yeah. So why don't you talk a little bit about how important advocating and making it known that we needed to make sure that we had a physician that was directing traffic as it relates to the continuity of care and making sure that the protocols, everybody has the same protocols.
So I'm going to answer that in two ways, if you don't mind.
Yep.
First, because the question you ask about advocacy is incredibly important. If for all physicians, I think we care passionately about providing the best care for our patients. We have done ourselves a disservice by focusing only on patient care. And the problem is when we do that, we allow others to write rules and influence policy in a way that may not have patients and the center of the reasons for doing things. So what I'd like to do first, I want to come back to that advocacy question because it really is important. But let me just give you an overview of what's happening and why it's happening.
Right.
So for the last 40 years, EMS transport and emergency medical care has been done by something called a public utility model, which is a way of financing and running a system. And that was collectively called MedStar. Right. So MedStar did all 911 emergency medical transport and interfacility transport for everywhere within the city of Fort Worth and our 14 member cities. So that's been in place for 40 years. For the last 20-ish, since 2009, they did that with zero tax subsidy. Now, as everybody who is listening to this podcast, I'm sure, is well aware, the reimbursement landscape for medical care is changing dramatically.
Right.
EMS is not reimbursed. Here's a fun fact for you. Under Medicare, it is listed as a transport benefit, not a medical benefit, which means the way it's reimbursed is different. The bottom line is that you cannot continue to fund an EMS system like MedStar with zero tax support. So the policymakers, Mayor Parker, other council members, had to decide how to fund the EMS system. At the same time, because of a lack of resources into the system, we were having challenges meeting response times, we meaning MedStar.
Right.
So mayor and council decided that they wanted to bring this into city so that we're providing it with city employees, and they specifically decided we'll do this as part of the fire department. And we will do so with tax supplementation. So obviously we're going to continue to bill for service, but the taxpayers will support the system, which is what 98% of America pays for.
There's always a cost to doing business.
Absolutely.
Right.
And basically they said if we're going to put the money in, we want to be ultimately accountable for it. Understandable. So as of July 1, EMS service, 911 service in Fort Worth and our member cities, all of the member cities came together and said, we want to continue this joint system, will be provided by the Fort Worth Fire Department. Now, to get to advocacy a little bit, where the advocacy comes up is Tarrant County Medical Society, let's go back 40 years ago, was instrumental in the design of the EMS system. And they designed it in a very unique way for 40 years ago. They said, we will have someone to run the operational business of EMS, and we will have a separate entity overseen by physicians that looks at the medical practice. And we'll call that thing the Office of the Medical Director. So it was designed to maintain independence of medical direction. So the reason for that, in some systems, the medical director works directly for the operational department. And then what happens in some places, clearly not here, but in some places, you have medical practice dictated by non-physicians. Now, there are a couple of things that are unique about Texas. One, we have a constitutional prohibition against the corporate practice of medicine, which says that physicians need to be in charge of physician and medical practice. The second thing is that in many states, there is a defined, legislatively defined scope of practice for EMS clinicians. That scope of practice does not exist in Texas. Texas is called a delegated practice state, which means Texas gave me the right to do an appendectomy. Very bad decision as a non-surgeon. I think they shouldn't have. They might have wanted to think twice about that. But they also gave me the ability to delegate that. So I can delegate that practice to all of my clinicians. However, I have to be sure that they are competent to do that, which means I have to credential them. Just like a hospital would look at me and go, there is no way I'm credentialing you to do an appendectomy. You're not a surgeon. Smart move. So I have to credential the medics in the system. So where advocacy comes in is there was a question, we're building a new system. Do we want to maintain this independent medical oversight? TCMS and the physician members of TCMS stood up and said, absolutely. This is critical.
And we will die on the hill.
It was very clear. I'm very, very thankful for that. And the reason I'm so thankful for it is I think this setup allows us to focus on the needs of our patients. And to be clear, that does not mean that anyone on the operations side doesn't care about patients. We both do. This is something we're both committed to. All sides of the fence, but this independent approach really helps us stay focused on that.
Doctors doing what doctors do. And what doctors were trained to do. And this, again, was a huge scope issue for us. And we're happy that you're leading the charge on this. That's for
Well,
sure.
I very much appreciate the support. What I can tell you about this is I'm very optimistic about the system that mayor and council have designed. They've built some things that are very unique into this system, things that really don't have a lot to do with medicine but are critically important to the ability to deliver good care. I think it's wonderful. I'm not going to bore everybody with the operational details, but I'm optimistic about it.
Let me ask you something. Now, I heard something. Is there something else going on, like that's being built, a command center? So if there's an emergency or something going, making sure, again, that all the communications and everything is being fed, right? It's a kind of fail-safe system. Isn't there something else going on behind?
There is. There's a 911 review process. So, and by 911, we're not talking about changing the number here. We're talking about how to handle the processing of 911 calls.
Got it.
So MedStar responds to about 200,000 events a year.
Right.
Fire run, I honestly don't know how many, but it's thousands. Law enforcement runs hundreds of thousands of events. That is a massive amount of 911 traffic. What is going on is mayor and council are trying to identify the best way to process those calls.
Because let's be honest.
Sure.
We know that there are a lot of people out there. We hear stories all the time that sometimes they don't know any better. They'll call 911
Absolutely.
and you hear the crazy stories about, well, I want somebody to come, I got to go pick up McDonald's, right? And these are not crazy stories. Or people using the 911 system.
Well, they may be crazy stories, but they're true.
But they're true stories, right?
Yeah.
And, we really, 911, at least when I grew up, and when I would never even think, I think most people would be hesitant even to abuse 911. I mean, this is used for emergency.
Right.
And you do not want to be in a line where you're denying or somebody's dying by the roadside because you abuse 911. So, trying to sort out these calls on non-emergent versus it can wait.
Yeah, absolutely. Two things about that. One is who does it, and two is how do we do it. So what mayor and councilor the policy decision that they've made is to integrate all three service lines, law enforcement, fire, and EMS, into one center. So we are doing that literally as we speak. And what is happening, instead of a call going to one location and then being transferred over telephone lines to an entirely different location with different people, that's all being brought in to one place. So a lot of technical things are happening to make sure that there are no delays in call processing. Right. We're trying to process these calls as fast as we can, and I'm very optimistic about what is going on here. That it's a really good thing. So that's number one. Number two is this issue of low acuity calls, and we are doing some things that I think are really exciting. So the reason I think it's always helpful to say, well, why are people abusing the 911 system? Right. They're doing it because they have very few other options. And if they do have other options, they don't know what they are. Right. So people have legitimate needs, and they are calling to try to identify how to meet those. We have an obligation to help meet those. Sure. So when we get there, it may be really obvious to us that they don't have an acute medical emergency and may not even need to go to the emergency department, but they do have a medical need. We need to figure out how to best handle that. We are looking at some really interesting ways of using telemedicine. So one of the things that we're doing that I think is very exciting is when someone who knows they have a medical problem but doesn't know whether it is an acute issue or not, when they call 911, we'll run them through the normal medical triage process. And if we identify it as a low acuity emergency, we give the caller the option of talking to a physician right there over an app. We push a link out to their phone, and it establishes a secure, HIPAA-protected consult with a physician. Right. The physician then can meet their needs, whether that is calling a prescription, whether it is help with transport, with Uber, with Lyft, something like that. also puts them in contact with a case manager to help identify resources, do all the stuff that the patient needs. So that is a wonderful opportunity to not send an ambulance at all. And the reason we want to do that is not because we don't want to send an ambulance, but we have more calls than ambulances, and we want to send the ambulances where the acute need is. Now, we may not be accurate in identifying that call, and what we do is we err on the side of assuming that any problem is more acute than perhaps it is. So if we're going to make a triage error, we want to over-triage that.
Right.
So we have situations where our clinicians will show up. Then once they assess the patient, it's really clear it's a low acuity problem. They also have that ability to push out that link and establish that telemedicine visit.
Does the system, for example, and we talk a lot about this with the people who maybe overutilize the emergency department, right? And they're called frequent flyer people. So in this system,
loyal patients.
Sure. So would this system, for example, so if Jane Doe called, right, 10 times that month,
right,
would there be kind of, okay, we know Jane Doe might be calling about this particular thing.
Yeah.
So there is a sophistication to it where.
So Jane calls. 10 calls a month would be doing well. She calls 10 times a day. And we do have a special, these are special patients, so we have a special program. We will write patient-specific medical directives. I will review the situation. We have staff in OMD that helps us do this. We review their medical visits. We see what's going on in the emergency department. We look at their problem list, identify what evaluation has been done. And when we identify that these are not patients who are best served by reinforcing the behavior of taking, it's almost always secondary gain. So we will say this is a patient-specific protocol. If it is an opioid abuse situation, then it is we won't give opioids for this patient. If it is a doctor shopping, we're bouncing from hospital to hospital, that's not good for continuity of care. We identify one home hospital. If we identify the issue is they are calling for whatever the secondary gain is, once they have really demonstrated, and we're talking 50, 60 calls in 90 days, and they are low acuity, they become eligible for what's called a medical director refusal. So they are requesting to go to the hospital. Our clinicians identify the patient, put the crew in touch with one of our EMS physicians. We have 3 medical directors here. Then we'll assess the situation and say, we are not taking you to the hospital.
Got it.
You really have to work hard to get into that group.
Yeah.
So, examples of this are people are seen in the emergency department, receive a medical screening exam. The qualified provider, and I'm using these terms very clearly, the qualified medical provider determines that there is no acute medical emergency, discharges the patient. The patient does not even leave the hospital and calls 911 again, asking to go to another facility. We are not going to transport that patient, but that's a physician decision. That comes to one of the medical directors.
Right. So with the one of the things, again, I learned through this process is this system, second to none. I mean, we had people come up, consultants, that kept saying that, again, our system here is a model for the country. And I think about when we were going through this process, and again, I know if I start naming names, I'm going to leave people out. But, you know, I'm thinking of the Terry McCarthy's and the Raj Gandhis and the Steve Martins who have been around, right, for so long. And again, being able to just build on those giants that were here in the beginning, that we can assure the public that this system is going to serve the needs. And again, doctors being in charge of the cares and protocols
medical
and
practice.
continuity. That is key, and it's not going to change.
Correct. Absolutely. So we are, and the other thing I wanted to point out is the 40 years of service of the members of the Emergency Physicians Advisory
Yes.
Board, EPAB. That was, members were appointed by TCMS,
Right.
And they served to make the system what it is now.
Right.
So I very much am appreciative of that service. The other people that really spoke up and helped were not just the physicians in TCMS, but our hospitals.
Yeah.
Because they
Yep.
recognize the value that OMD has provided. So I'm very thankful for the medical community here. I've worked as a paramedic in 3 states, as an EMS medical director in 3 different systems. I lecture around the country. What we have here in Tarrant County is unique. I have never seen an EMS medical practice better integrated into the larger healthcare practice than I have here. Awesome. It's a pleasure to practice here.
So I think we'll end it. We got a lot more we can talk about, maybe another episode. But if somebody needs to get a hold of you, right? So
absolutely.
why don't you? Where do you get a hold of you?
Yeah.
And even if we got our young students out there that want to talk to you, right?
I benefited tremendously from amazing mentorship.
Mm-hmm.
I feel an obligation, like I think most of us do, to pass that on.
Right.
I would love to talk to any medical students who want to go into emergency medicine or EMS.
Yep.
As I was leaving a meeting this morning at OMD, we had 2 emergency medicine residents that were there learning about EMS. So very happy to help anybody about it. Best way to get a hold of me, I think, is my email address. Yep. It's Jeffrey, and it's spelled the correct way, Jeffrey, .Jarvis, Jarvis, at fortworthtexas.gov, and Texas is spelled out.
Or they can call us.
Absolutely.
I got your number,
Absolutely.
that's for sure, on speed dial.
Exactly.
But we're going to wrap it up here. Make sure everybody checks out our links. Please share this video, and we'll see you next time on the Tarrant County Medical Minute.